Good evening in Asia, good morning in Europe. I'm Christophe Leclerc. I'm very pleased to welcome you in the 2020 ESC guidelines on atrial fibrillation session in the ESC Asia 2020 with the Asia Pacific Society of Cardiology and the ASEAN Federation of Cardiology. We will have a very fruitful discussion about the guidelines. And it's my pleasure to welcome our panelists, Tatiana Papara, Dr. Sofiane Johar, good evening, and also Professor Chin Chi Keong from Singapore. Now we will have the opportunity to listen to one of the two chairs of the ESC guidelines on atrial fibrillation. The two chairs were Tatiana Papara and Gerd Hendricks, and we will have a video from Gerd Hendricks. We will summarize the key point of the ESC guidelines. Now we are listening, Gerd Hendricks.
The 2020 atrial fibrillation guidelines introduce a whole set of new ideas and new evidences how to deal with patients and for patients with atrial fibrillation. Let me start off with one of the principal changes of the 2020 atrial fibrillation guidelines with respect to the perspective on atrial fibrillation. In the past, we graded patients with atrial fibrillation mostly based on ECG phenotyping, paroxysmal persistent, long-standing persistent atrial fibrillation. We believe that this is no longer adequate, but we have to take a wider scope and a wider view on patients with atrial fibrillation. So we've introduced the 4S scheme for characterization of atrial fibrillation that provide more insight into the clinical status of the patient. It provides insight into the substrate of the patient with atrial fibrillation, and it has an impact on the development of therapy streams for the patient. So that is one of the key innovations. The second innovation that makes management of patient with atrial fibrillation more intuitive and easier is the ABC pathway. The A stands for avoid stroke and consider anticoagulation to prevent the devastating complication of stroke. The B stands for better symptom care. Look for quality of life, improve the patient's quality of life. It's so important for patients with atrial fibrillation, not only to prevent complications, but to improve quality of life. And the C stands for comorbidities. Atrial fibrillation stands not alone in the health status of the patient, and it's usually in line with quite a number of comorbidities: diabetes, hypertension, chronic kidney disease, coronary artery disease, obesity. So consider these comorbidities more serious in the future than they may have been considered in the past. Talk to the patient about the importance of lifestyle changes in order to reduce the risks that go along with comorbidities. One key element that makes that very, very clear what the patient himself or herself can do is the obesity issue. If you lose weight, your quality of life will improve, and the atrial fibrillation burden will by itself decrease only by weight loss. So there are huge opportunities in that field. Aside from that, we have updated the recommendations for interventions in the field of catheter ablation rhythm control strategy, and I would like to focus on one key element that refers to catheter ablation of atrial fibrillation in patients with heart failure, as we believe that patients with heart failure and reduced ejection fraction have the highest likelihood of gaining profit for quality and quantity of life by catheter ablation. So overall, the 2020 AF guidelines on atrial fibrillation management put a clear focus on patient values and quality of care in and around treatment of atrial fibrillation.
after the key point presented by Gert Hendricks, now we will have a discussion with the panelists. And we will start with the letter A, avoid stroke. And I will ask Sofiane to present in 1 minute the key point of the A pathway. Please, Sofiane.
Thank you very much. The ABC pathway is actually a very easy way to think about the approach to treat atrial fibrillation. A stands for anticoagulation and to avoid stroke. So basically, if you look at the guidelines, in general, they ask you that you use the CHA2DS2-VASc score, which we all know, in order to actually make the judgment as to whether someone might benefit from anticoagulation. And in general, if your CHA2DS2-VASc score is 1, more than 1 if you're male, and more than 2 if you're and 2 or more if you're female, is basically when you consider anticoagulation. And the guidelines do make a point of indicating that a NOAC, a novel or non-vitamin K vitamin K oral antagonist, is actually the preferred option. Warfarin still remains an option if you have a well-managed TTR of more than 70% or time in therapeutic range. One of the things the guidelines also looks at is a clinical question is when you have acute coronary syndrome and coexisting atrial fibrillation. In general, they actually only recommend nowadays triple therapy for less than 1 week and then dual therapy afterwards to reduce risk of bleeding. And if you have a chronic coronary syndrome, then anticoagulation with oral anticoagulant in combination with dual therapy is only recommended for up to 6 months. And then if the next slide will actually show a very nice pathway where, in terms of assessing whether someone needs anticoagulation. And essentially, everyone should really be considered for anticoagulation with a non-vitamin K oral antagonist, unless you have a prosthetic mechanical heart valve or moderate severe mitral stenosis. Thank you.
Thank you, Sofiane. And I think that we can discuss with the 3 panelists. And one point I want to stress, and Tatiana probably can highlight us about the choice of the guidelines to promote new anticoagulants as compared to non-vitamin K antagonists.
Thank you, Christophe. Well, accumulating evidence that is pretty much comprehensive convincingly shows that in NOAC-eligible patients, that is those without prosthetic heart valves or significant native mitral valve stenosis, NOACs have a number of advantages over vitamin K antagonists. And that was the reason to recommend the preference towards NOAC in comparison to vitamin K antagonists in general in patients with atrial fibrillation. And available evidence also suggests that if you look at different subsets of AF patients, NOACs provide significant advantages as compared to vitamin K antagonists.
Thank you very much. And I think something also which is very important, Sofiane, is that you have to prescribe anticoagulants, whatever is the pattern of atrial fibrillation, for example, paroxysmal as well as persistent or permanent.
Yes, that's right, actually. One of the things the guidelines do say is that the pattern of atrial fibrillation makes no difference as to your decision whether to anticoagulate someone or not. They're all treated as the same as far as the guidelines are concerned, perhaps something that we don't readily appreciate, but that's certainly emphasized in the guidelines.
Thank you very much. You point in one of your slides the patient with acute coronary syndrome. And one of the key points of these new guidelines is you have to reduce the length of the triple anti-platelet and anticoagulant therapy. So I think it's a very important message for patients who have acute coronary syndrome to reduce the double antiplatelet therapy for 1 week, if it's possible. I have a question from the floor, and perhaps Professor Qingping can answer about that. It's about patients with device-related atrial fibrillation. When do we have to start anticoagulation? The question is, what is the duration of the atrial outrate episode to start anticoagulants? Please.
Thank you for that question.
No, I think if you have a device, a pacemaker, and you see atrial heart rate
Yes, I heard.
declines.
Yeah. Thanks for the question. So we are talking about subclinical atrial fibrillation or CIED detected atrial fibrillation. I think the guidelines in ESC 2020 has given very elegantly principles to consider anticoagulation. In short, if someone has an episode that is less than 23 hours detected on the CIED, he has a 2 out of 5 chance of developing a 23 hours and above duration of AFib in the next 6 months. Number one. Number two, for those with a CHA2DS2-VASc score of 2 with negligible stroke risk, has that tripled within 6 months if the duration of AFib goes up to more than 23 hours. So my advice is that to assess the patient for the burden of AFib regularly, because that burden changes over the time of 6 months to a year. And number two, pay particular attention to those with a CHA2DS2-VASc score of 2 and above. With the safety and efficacy of NOAC based and derived from patients with clinical atrial fibrillation, we are a little assured that the safety of these drugs offers good benefit in stroke reduction. Over to you, Christophe.
Thank you very much. A final question for this topic to Tatiana. Now we do not have to discuss about valvular and not valvular atrial fibrillation. Can you comment briefly on that?
Yes, thank you for that very important issue, because in the past, such categorization have been caused a lot of confusion. So we have strongly recommended against using such classification of atrial fibrillation. So the recommendation is to describe such patients as patients with atrial fibrillation and valvular heart disease, not valvular AF. And that's important to avoid confusion in communication and treatment decision making.
Thank you, Tatiana. Now we will move to the letter B, and I will ask Ching-Kian Cheng to comment his slide.
Please. Thank you. B refers to better symptom, and rhythm control strategy refers to attempts to restore and maintain sinus rhythm, usually with various treatment modalities. And on the left side of this chart, after establishing stroke prevention, rate control, cardiovascular risk reduction, then we assess if the patients would benefit from rhythm control. If symptoms are absent or uncertain, it is reasonable to adopt attempts in rhythm control and therefore assess the symptoms thereafter. If symptoms are clear, we could restore or attempt to restore sinus rhythm in these patients. Let me draw your attention to the center of this chart on factors favoring rhythm control. We really should offer rhythm control in younger patients, patients with first episode AFib, short duration, who may have tachycardia-mediated cardiomyopathy, fairly normal heart structures and function, little or few comorbidities, or they have rate control that are difficult to achieve. And also, we will have to respect the choice of the patient. After deciding on rate control strategy, it would be a combination of antiarrhythmic drugs and catheter ablation. And let me draw your attention to the right side of this chart that amiodarone is recommended for long-term rhythm control in all AFib patients, including those with heart failure with reduced EF. The recommendation has upgraded from a class 2A to a class 1 recommendation, though other antiarrhythmic drugs should be considered first whenever possible. Now, on the role of catheter ablation, it is chiefly for patients with symptoms and who have failed rhythm control or intolerant to class 1 or 3 antiarrhythmic drugs. You could see that there is an upgrade of guideline from 2A to 1 for patients with paroxysmal atrial fibrillation, persistent AFib with major risk factors for AFib recurrence, or persistent AFib without major risk factors for AFib recurrence. And lastly, as a first-line therapy for catheter ablation, it's a class 1 recommendation if that patient has
tachycardia-induced cardiomyopathy of high probability, independent of symptom status. In patients with reduced EF and heart failure, catheter ablation to control atrial fib remains a class 2A indication. Over to you, Christoph.
Thank you very much for this very nice comments. And we have a question from the audience. What is the role for you of AF ablation as a first-line therapy in patients with paroxysmal atrial fibrillation?
The guidelines is still clear that for first-line therapy, before taking a medication, be it beta blockers or antiarrhythmic drugs, it will still be a class 2A indication. All right, respecting the patient's choice and the desire to be free of drugs. AFib ablation, when done in experienced operators, is efficacious and fairly safe in high volume centers. So that should, or rather may be commenced or explored, provided we have gone through the complications, the benefits, the risk, or alternative to AFib rhythm control with that patient before proceeding for a AFib ablation.
Thank you very much. For rhythm control, if you want to use antiarrhythmic drugs, the top antiarrhythmic drug is amiodarone. So do you use Sofiane amiodarone as a treatment to control rhythm in patients with atrial fibrillation? Because we have to balance with the side effects of amiodarone.
That's right. I do use a lot of amiodarone, but generally speaking, these are for patients who have tried one of the other drugs first, like a beta blocker or a rate-limiting calcium channel blocker. Amiodarone I use fairly often in those patients who are quite symptomatic in terms of their rhythm, but who for some reason cannot undergo cath ablation, because in general I would prefer to have these patients undergo cath ablation. But actually in this part of the world, amiodarone cath ablation is actually quite hard to access. So vast majority of cardiology and general physicians out there, the message from the ESC that amiodarone that is a reasonable choice and for these patients is a good one, respecting that perhaps other antiarrhythmic drugs should be tried first, and to always monitor and counsel the patients about the many side effects which we know amiodarone has.
Thank you. Tatiana, you increase the role of AF ablation in patients with heart failure, probably due to especially the CASTLE-AF trial. So what is your clinical practice when you have a patient with persistent atrial fibrillation and left ventricular ejection fraction of 30%? Will you move quickly to AFib ablation in this patient?
Well, in general, I would strongly consider going for a catheter ablation, especially depending on the overall patient risk profile. And as I wanted to mention also for the previous discussion, it is very important to involve patient into active informed decision making. So patient preference is very important. Then for patients with heart failure, increasing evidence suggests that selected patients with reduced left ventricular ejection fraction would really benefit from catheter ablation as a first-line treatment. So I would, in brief, I would consider it.
Thank you very much. I think it's a very important new feature of the ESC guidelines on atrial fibrillation. So now we will move to the last talk, the see later, which is very, very important. And Tatiana will comment a slide about the comorbidities and cardiovascular risk factor management.
Thank you, Christoph. Indeed, if you look at clinical practice and epidemiology, atrial fibrillation rarely comes alone. It's often accompanied with cardiovascular risk factors, structural heart diseases, other medical conditions. And it's very important to keep in mind that those AF risk factors are not independent one from another. They potentiate each other and promote the development of atrial arrhythmogenic substrate, and increase the development of arrhythmogenic substrate, on the other hand, promotes development of atrial fibrillation and also translates into poorer outcomes with rhythm control strategies and translates to decreased survival. And there is an increasing number of observational or post hoc analyses from randomized clinical trials showing that only integrated AF management with comprehensive identification and addressing of concomitant diseases and cardiovascular risk factors translates into improved patient outcomes. So, as you said, Christoph, C component of the ABC management is equally important as the first two. And that is why we provided a set of recommendations in the 2020 ESC guidelines. And also, what is important to keep in mind, it is not to pick one and manage it aggressively. It is to pick all concomitant conditions that the patient has and address them equally aggressively. So only then there will be improvement. So it's a holistic, it's very important to provide to patient a holistic care. Thank you.
Thank you very much, Tatiana. I think it's a very important point of the guidelines and probably something we forget when we manage patients with atrial fibrillation, because I think there is now a clear message for anticoagulation using the CHA2DS2-VASc score to go to rhythm control or rate control. But in clinical practice, usually we forget to look at the comorbidities. So Tatiana, before AF ablation, do you think that we have to first try, for example, in an obese patient to try to lose weight before going to ablation?
Absolutely. It has been shown that there is a significant correlation between body mass and the outcomes of AF ablation. And the effects of weight losing are sort of dose dependent. The more you lose in obese patients, the better outcomes of AF ablation will be. So definitely that's the treatment measure that must be considered and advised to patients. And I would also like to add that speaking about a holistic management of concomitant conditions, we believe that the failure of some observational or open label studies in the past to show that managing a specific risk factor is associated with treatment success and outpatient outcomes resulted from managing a single factor in patients with multiple conditions. So for speaking about that, in the RAISE-3 trial, for example, it has been elegantly shown that only comprehensive management of all present risk factors will result in improved outcome.
Yeah, I have a question, and Sophia, and perhaps you can answer that. How do you do in your clinical practice to manage all these comorbidities? Because it's very difficult to have the adherence of the patient, for example, to lose weight or to stop alcohol. So how do you do in clinical practice?
I think it's very difficult. Actually, in the ideal world, I'm an ablationist, so I always favor ablation. But actually, it's actually quite difficult to convince a patient once they've been referred for ablation that actually, I'm sorry, you have to go manage your risk factors first and then come back a bit later on. So in practice, what I generally do, actually, if I'm convinced that the patient is suitable for AF ablation, then I tend to do the ablation and then manage the risk factors. In general, hypertension and diabetes are the most common comorbidities amongst my AF ablation population. Obesity is also extremely common, but I'm afraid I have no magic bullet. So I think that a multidisciplinary approach is obviously best, especially obstructive sleep apnea, which is also fairly common. And I think we have to recognize our limitations as cardiologists. Perhaps I can manage their diabetes and to a certain extent, so hypertension, to a certain extent diabetes, but the rest requires a AF team, which I think your guidelines are promoting as well.
Yeah, I think you mentioned a very important point that AF management is not just a problem of electrophysiologists, but as AF team. And especially, and it was highlighted in the guidelines that we have to work with the patient for education and adherence to treatment, which is a very important issue. So, do you have a AF clinic in Singapore, for example, Chin Keong?
I'm afraid we do not have an AFib clinic in my center yet. I hope to set it up. We can manage these patients in a holistic, multidisciplinary manner.
Thank you very much. So, Tatiana, do you think that we underdiagnose the sleep apnea in patients with atrial fibrillation? And do you think that we have to be more proactive to try to detect sleep apnea in patients with atrial fibrillation?
Definitely, yes, because there are studies showing that sleep apnea itself, even without atrial fibrillation, has been associated with increased risk of stroke and also associated with increased risk of incident AF. And a suspicion to sleep apnea can be easily obtained through patient history. So I think that it's very important to keep that in mind and to search actively for
Thank
sleep
you.
apnea.
Thank you very much. We have a question which just came out about the NOAC, and we will come back to the NOAC. And do you think that the NOAC can be used in patients with, for instance, mitral regurgitation? Who want to answer to that?
I can answer briefly. I don't see why not. There is no data suggesting that we shouldn't.
The other question is about when you have a patient with atrial fibrillation occurring, for example, during a pneumonia, so in a septic condition. Do you consider this etiology different from a AF without sepsis to start anticoagulation and to keep on anticoagulation? Tatiana, do you want to answer?
Yeah, of course. Well, it's a very important question, and unfortunately, we do not have high quality data to inform optimal management of such patients. In the past, it has been believed that so-called acute atrial fibrillations or secondary atrial fibrillation is provoked by temporary change in the physiology, so that it was transient and that it would disappear with treating the main cause. However, increasing body of evidence suggests that in patients experiencing atrial fibrillation in acute illness, there is a higher risk of recurrent AF later in life compared to those who went through acute illness without having atrial fibrillation. So again, we need a very careful individual patient assessment, but in general, most patients would clearly benefit from a course of oral anticoagulant therapy. It's unknown for how long, but we should always keep in mind that the risk of recurrent AF is increased, and the next AF may clinically manifest as deleterious stroke. So whenever we anticipate a positive net clinical benefit, especially if the patient has a high CHA2DS2-VASc score, it is prudent to keep the patient at least several years on oral anticoagulant therapy.
Thank you very much. Another very important question is the management of anticoagulants after a successful ablation of atrial fibrillation. So, Sofiane, what is your clinical practice? You ablate a patient, you think that it's a success. What will you do with the anticoagulants?
Actually, I base that decision solely on the CHA2DS2-VASc score. Basically, even though you may be successful, there's always a small but definable risk of AF recurring. So in general, I will just strictly follow the CHA2DS2-VASc guidelines. If they meet the criteria for anticoagulation, then they stay anticoagulation for the rest of their lives.
Yeah, thank you. I think it's a very important point because some patients are expecting that after atrial fibrillation ablation, they will not receive any anticoagulants. But I think that when we discuss with the patient, it's a very important point we have to stress that whatever is the result of ablation of atrial fibrillation will not change the management of anticoagulants. And I think it's very important information to give to the patients. And also we have a question, why did you suppress the lone atrial fibrillation concept in the guidelines?
Well, again, increasing evidence suggests that in many cases, although it's apparently healthy patients with incident atrial fibrillation, which we used to call lone atrial fibrillation, in essence, atrial fibrillation is a marker of subclinical disease that will become evident in most of such cases within the first year of the diagnosing of AF. So it's, as I said at the beginning of my presentation, AF very rarely comes alone. If a concomitant underlying disease, medical condition is not evident at the time of atrial fibrillation, it will soon become clinically overt. And that's the truth in most of the cases. It's only a matter of our clinical tools, whether we are able to detect it at the very beginning of AF.
Thank you, Tatiana. We have a final question for Jin-Keong Cheng about atrial ablation. And what do you consider as the limit to proceed AFib ablation in terms of dilatation of the left atrium?
I'm sorry, I didn't catch the last bit.
No, I think the question is, which side of left atrium do you consider to avoid AFib ablation?
If you are referring to the endpoints of AFib ablation, the clinical endpoints is first to establish good pulmonary vein isolation at the antral region. That's the most important. Thereafter, the additional ablation depends really on the substrate, and the rest are really at most 2B indications for additional ablation. If they have a concomitant atrial flutter that is CTI dependent, that should be ablated, or a macro-reentrant atrial flutter involving the left atrium, a linear ablation to terminate that should be done. So in short, a good PVI is the cornerstone before doing additional ablation.
Thank you very much. So now we have to close the session. I would like to thank Tatiana, Sofiane, and Jin-Keong for their participation to this session about the ESC 2020 guidelines of atrial fibrillation. And I wish you a fruitful and very interesting meeting, ESC ALIA 2020 with APSC and FAC. Thank you very much to all of you, and thank you to the audience for attending.